So thank you, Beth, for inviting me. And I look at all of you as the people who might be the ones who lead our country and the practice of medicine back to freedom from the direction that it's going. And so from my perspective, you might be a small amount of people in this room, but nothing is ever led by big groups. It's led by individuals in their own little places. And so I'm excited that you're here to, get this perspective of freedom, to give me an opportunity to talk with you about privacy and how our organization views privacy, the importance of it, and then to have an opportunity to converse with you. Now, just hold for one little second here, because I wrote something that is to myself, notes to myself, that is not up there, and I don't want to miss them. Don't you love it when your computer says, no, that's not the right code? Okay, all right. So sometimes I start out with the 5 things you need to know about healthcare that a lot of people don't talk about, and but there are more than 5, but I've only given you 5 here. So the first thing is there's no such thing as healthcare. There's no such thing as healthcare. There's health insurance, there's medical care. But that conflating of the two together, so when people who have employer-sponsored coverage say, I get my health care at work, that kind of conflating is how we're moving as a country towards socialized medicine. And socialized medicine is the merger of the delivery and the financing of healthcare. And so in people's minds is the conjoining of the two of them together, which is better to, every time you talk about health insurance versus medical care, whenever you can. Sometimes you have to say healthcare to get people to even understand to start, but then you can mention this. Another thing is that health plans are not insurance. This is one of the things people don't understand. Health plans are not insurance. Health plans are prepaid health care. Health insurance is for the insurable catastrophic event. It's sort of like home insurance, right? Home insurance is not for the replacing the carpet or painting the rooms or whatever, right? It's for when the house is burning down or when it's flooded and it's a disaster, right? So, but that movement for people to think of health plans as health insurance, when health plans are the merger of the financing and the delivery, they're telling doctors how to practice medicine. Some of them are actually have practices themselves. Now we have hospitals that are buying health plans and health plans that are buying hospitals. And that kind of merger is just like the corporate version of socialized medicine. So the Affordable Care Act actually prohibits catastrophic coverage. Those words are in there. Catastrophic coverage is prohibited in this country, which is the traditional kind of insurance. It's prohibited, and all that's left is managed care organizations or health plans. And then one other thing that I wanted to give you is I want to give you a formula, which is not on here. HIPAA plus EHR plus HIE plus CDS plus P4P or VBP, plus managed care medical education means outsiders are in control. Now, how many of you understood every one of those acronyms? Okay, one. Okay, let me just be clear. HIPAA, which I'm going to talk about here, the so-called privacy law, EHR, electronic health record, plus HIE, health information exchange, plus CDS, clinical decision support, plus pay for performance or / value-based payment, plus managed care medical education is outsiders in control. This is the formula of where the entire country is moving. Okay, now, with that as just a background, I'm going to start this PowerPoint presentation. I was asked to talk about privacy in the era of EHRs, and because our organization, Citizens Council for Health Freedom, believes that he who holds the data makes the rules, which then shows you how privacy is foundational to having freedom in this country, freedom for the doctor and freedom for the patient. Okay. So I want you to understand how this health surveillance system and the taking away of privacy has happened in this country. And you can go, and so I'll just tell you a few things about each of these. The Clinton Health Security Act created an electronic, it didn't pass, but what was in there were practice protocols for physicians, an entire national electronic medical record system, and a unique patient identifier, unique provider identifier, all these unique identifiers. And then the Health Security, Portability, and Accountability Act actually took the unique identifiers and the administrative simplification piece of the Clinton Health Security Act and passed it as a bipartisan bill in 1996 called HIPAA. 1999 was the beginning of value-based and quality-based measurement of doctors. It was started as a voluntary, and then it has been made mandatory. In 2004, George W. Bush did a State of the Union speech in which he talked about electronic medical records. The group who pushed that, called HIMSS, the Health Information Management System Society, just had their big conference. I was just at it in Las Vegas. Nearly 45,000 people there, a small city. They pushed to get that one line into President Bush's State of the Union speech. And then from there, he did an executive order creating a new agency in the government called the Office of the National Coordinator of Health Information Technology. In 2006, the Tax Relief and Healthcare Act, just trying to remember which one that had. Yeah, that's where, I believe that's where the quality reporting went from voluntary to mandatory. And then the Genetic Information Non-Discrimination Act of GINA, I just put that in there because it doesn't really protect genetic information, but it sounds nice. 2009, high-tech. So high-tech is a law that is inside the Recovery Recovery and Reinvestment Act, which was passed less than 30 days after the inauguration of President Obama. The HITECH Act forces all practitioners to have an electronic health record. It also required meaningful use, which meant it had to be used the way the government said it had to be used. It had to be certified the way the government said it had to be certified to do. And that's why we have all these electronic health record systems in this country. It was considered the foundation of the Affordable Care Act because the only way to do what they wanted to do was to be able to have all these electronic tracking systems around in the hospitals and in the clinics. Then came MACRA, which is the Republicans put in, and MACRA created, it really embedded what the Democrats and President Obama did by saying that you'd get paid for certain things. And then the 21st Century Cures Act said there'd be no information blocking and created an information commons out of which to do research without patient consent. The Consolidated Appropriations Act, I guess the one thing for you to understand before I say that is that when HIPAA was passed in 1996, the unique patient identifier was required. The National Patient Provider Identifier was required. But the unique patient identifier was prohibited in 1998 and has been prohibited every year since, starting with Congressman Ron Paul, who made sure that it couldn't be developed and there could be no funding for it. But in the Appropriations Act of 2017, they released that, allowing a lot of money to create a national patient matching strategy. And when I was at HIMSS, I heard the person who pushed that, who said, I thought that maybe if we called it a national patient matching strategy, that would be more palatable sounding than a national patient ID. So those who want a national patient identifier for tracking and access to care cheered after President Trump signed this law. And then there are these two bills right now going through. One would give the health data clearinghouses the ability to use and share all the data that they have, which is 90% of all the claims data in the country. And then the substance use disorder bill, which would say that people who have been treated for substance abuse would not be able to have any control over where the substance abuse records went. So those are some of the actions leading us to no privacy, no control, and the end of freedom in this country. So a lot of people think that HIPAA has something to do with privacy, but it's really called a disclosure rule. People call it a privacy rule, but that's not true. There's one attorney, Nicholas Terry, who says it's a misnomer to call it a privacy rule, and that's absolutely true. And it is known for the fact of all its permitted disclosures. So it's considered a permissive rule. HHS Secretary at the time, Donna Shalala, talked about the age-old right to privacy in this new world of progress, and then promptly proceeded to put out a rule that had 12 national priority purposes for which data could be shared, plus payment, treatment, and healthcare operations. Under the rule, 2.2 million entities can have access to information. Entities, not people. Entities can have access to information without patient consent if the covered entities provide them with access. Covered entities are doctors, clinics, hospitals, and data clearinghouses, although data clearinghouses are restricted by a business associate agreement, which is why they can't share like the others can. And then the health plans are also covered entities. So here is a chart. I don't know if you can, I guess it's big enough there, right? 1.5, this is from a federal rule in 2010. So 1.5 million business associates, and then over 700,000 covered entities. And under HIPAA, all of these can share, use, disclose, access data as long as the covered entities give it to them without patient consent. So to payment, treatment, healthcare operations, I really think it's important for you all to understand what that is, because you probably have a definition in your mind, but the federal rule has its own definition. Treatment is 62 words, payment is 64 words, healthcare operations is nearly 400 words. Now, the interesting thing that happened when Shalala put out the first proposed rule is that 52,000 comments came in. That's almost like a record in the federal government, and most of them asked for patient consent. And so the Clinton administration put back in consent for payment, treatment, and healthcare operations. But as soon as President Bush was inaugurated, the industry came to President Bush and said, please open that rule back up and get rid of that consent. And that's exactly what happened. And so we don't have consent. And sometime I just encourage you to look up healthcare operations definition and see. And this is where those 1.5 million business associates get all your information for all of these things that have nothing to do with direct patient care. And as a matter of fact, I just read a quote by some physician who gave up his practice with 3,000 patients, in which he said he had meaningful relationships with all of these folks, 25 years of a practice, and he said he could not do it anymore because he couldn't tell them where all their data was going, but he knew it was not for their direct patient care, and he just felt it was a violation of his practice. There are no accounting of disclosures required unless the state law requires it, because state law can preempt everything here, but most people think that HIPAA is privacy, and so they have actually said in their state law that they will follow HIPAA in order to protect privacy. But as soon as they do that, they've given up all privacy. When the Bush administration came up with their revised rule, they created this thing called a limited data set. And the limited data set is for researchers, public health, or healthcare operations, the 400-word definition. And it's really not a limited data set. It is the entire set minus 16 identifiers. But it is still considered an identifiable set of information. And so some of the things that are still included in this set is the city, state, zip, date of birth, date of death, etc. So it's considered identifiable. There's no authorization or consent before this information is given out, no accounting of disclosures, and again, and then there's a data use agreement that has to say that you will not further disclose, you will not attempt to identify who these people are, even though it is it's still considered an identifiable, because as soon as you match it up with a publicly available database, you have these people. Okay, so the next thing for you to know is the EHR Meaningful Use Mandate, which was in the Recovery Act, high-tech. So meaningful use is as defined by the federal government and determined for most people who have EHRs at this moment, it determined whether or not they got money to partially pay for the implementation of this unfunded mandate at a maximum of $44,000 per practitioner, or let me just think, what was the other number for hospitals? I can't think of the number. But anyway, and forget the her in there. The problem with EHR is it always corrects to her, always. And the owner of Epic would like this now to become a comprehensive health record, CHR. And the only good thing about that is that every time you wrote it, you wouldn't have to self-correct it. But it's a bad idea. So what's required is that a government-certified technology be used, or you lose money every time with your Medicare patients, sorry, not Medicaid. So what we have done as our organization is we've called this the government EHR. So sitting at the hospitals and clinics are government EHRs. They are government certified. They have to do what the government says. They have to connect up. They have to share data. So it's not like the private free market EHRs that people had before the EHR mandate. This is the government EHR. $30 billion in incentive payments. Some say $37 billion has been paid from the federal government, but there are billions more that have been paid by industry because it's really an unfunded mandate. And it's just expensive even for offices to maintain, for leases, for interface fees, for all of these sorts of things. MACRA moved to merit-based incentive payments and to alternative payment models, and all of them include the use of the EHR. So now let's just look at MIPS for a second here, the merit-based incentive payment system, performing to the government tune, as it were. He who pays the piper picks the tune, and everyone is being paid. And you'll see here that these are the 4 things that practitioners are graded on for how much pay they're going to get. Quality, resource use, which means how much money you're paying. Your use of resources is going to be evaluated. Clinical practice improvement activities, and meaningful use of a certified electronic health record. Here's just another way of viewing it. If you can find this diagram in the Center for the Medicare and Medicaid documents. And here's, it's no longer called meaningful use. Meaningful use has morphed into this advancing care information, and this is the scoring for it. But it all has to do with sharing information and reporting information. And here is where you can get bonus points for sharing with the government, and you get an extra 10% if you have the certified technology. So it's all moving to being certified. Right now, a lot of people are in the 2015 version of the certified electronic health record and the 2017 to come. Now, ACOs is part of one of the ways that you can get paid, and I just put this in here. This is a version of the alternative payment model. I put this in here because it's such a wonderful quote from this chief information officer. To be an ACO, you need 3 things: a common EHR, a robust data warehouse, and a care coordination platform. If you don't have these 3 elements, you are flying blind. And that's because the ACOs really want to sort of track you at home. They're population-based, which means that anybody who might come in to the hospital or into the clinic, They're even using LexisNexis to figure out who the population could be, what their health is, and they're making phone calls to people to try and get them to be healthier so that they never come in. That's really, the ACO is to move everything into population health as compared to patient-based health, because their payment at the end of the day will be determined on their ability to do it this way. And now because I'm giving you different facets of privacy, I'm now going to move to what I consider coercive consent forms. So here's one from Essentia Health, which is in Minnesota. And I realize this is small, but what you just have to see is this page, and then this is part of that page. And no, wait a minute. I'm just going to make sure I got this. Okay, page 1, page 2. There are 23 items on this consent form, and there's one signature. This part here, so I got this from a patient who said, I don't want to sign for all of that stuff that's in that consent form, right? And at the very top of this consent form up here is consent for treatment, right? And then there's all these other consents, and then there's this one. And going back and forth with the hospital and our organization, hospital finally got to be okay with, okay, you can do the treatment, consent for treatment, and you have to do this one. This one. So this one, which actually you can probably read better than I can on my thing, you can see diagnosis, treatment of mental illness, alcohol, drug use, sexually transmitted diseases, HIV test, developmental disabilities, genetic testing, everything. In order to be treated, they wanted this signed. There was no option to just be treated. This is what we call coercive consent forms or consolidated consent forms. They are multiple consents and single signatures. And they put patients in a terrible position of giving up the goods of everything about their life in order to be treated. And that's unethical and not the way this should work. And so look at the consent forms and wherever you're working and see what they're forcing people to do. Now this comes because there's also, and you would see it in here, it's hidden in here because you can't, it's too small, but it says, I acknowledge that I have received the notice of privacy practices. Now, by law, you don't have to sign that. We have an entire campaign to get people not to sign that. Cross it out, whatever, don't sign it. The only thing the law requires is that you as a doctor or the hospital or the clinic have to make a good faith effort to get them to sign it. Why? So that they will believe they have privacy. That's why. In 22 meetings about 2 years ago with members of Congress and their staff, to a person, when we asked the question, what does it mean when you sign that HIPAA privacy form? To a person, they said it means that my information is between me and my doctor. And one attorney who is a staffer there said, I'm an attorney and I didn't even read this thing. Because as soon as you read the notice of privacy practices, you realize you have no privacy. It is a notice of disclosure practices, right? So in order to get people to understand this huge deception that has been foisted on the American public, we're asking people not to sign this. But doctors, hospitals are telling people, go away. If you don't sign this, go away. You don't sign this, we don't treat you. This is from the Office of Civil Rights at HHS, which says, if you choose not to sign, your providers still have to treat you. But doctors and clinics don't believe that, and they're worried about a HIPAA fine. So patients are actually being forced to go away, and patients are going away, as we hear from them. Okay, here's just another thing for you to understand, because I'm covering the waterfront, as it were, on privacy. Newborn-derived blood spots, I thought it was good for you to understand. This is baby DNA. There are at least 18 states that keep it for 10 years or longer, some of them indefinitely, sharing it, the DNA for research, et cetera, without parent consent or knowledge. As a result of our organization's work, there have been 4 lawsuits, 3 of them successful. The state of Indiana has 666 banker boxes filled with baby DNA from 23 years of people, many of them are now adults. And as a result of our work, they took those 666 banker boxes and said, we'll offer these to researchers without consent, although the people whose DNA it is can come and we'll give them their cards or we'll X them out. And into the future, we will get consent prior to storing and research. But these 23 years are available unless these people come. But of course, it's taken and it's stored without parents having any clue that it's happening. And so you as physicians need to understand this. And physicians a lot of times don't understand this because they don't do anything with this. It's often state mandated newborn screening. And so it's just done without a doctor's order. And so you don't even talk to your patients about what's happening here. Some states, as a result of our work, now allow patients to come and get their baby's card back. But some states, like New York, will give all the blood spots back except for one. So they keep it in the state repository, the DNA of every child born in New York. The Federal Common Rule does a lot of research on people without consent. And then there's this Employee Wellness Programs bill that would allow the DNA to be taken from employees without consent for worker wellness. It hasn't been passed. Information Commons for Research has been put into law through the 21st Century Cures Act. There's no consent for that. Creates this Information Commons, requires sharing by researchers the data that they get into a common pool for other people to use, permits access by all researchers regardless of training or motives. It's amazing the research that's done that could be considered objectionable to someone that didn't want to be part of that research. And then it creates a global pediatric clinical study network. And the people who have written on this have said this could cause concerns from parents. Okay, public health surveillance. Here's a comment in the public health reports about what public health surveillance is, or an electronic case reporting. So electronic case reporting, the automated extraction of data from the electronic health record by the state health departments or by the CDC. And then of course it says it's real-time surveillance without burdening the healthcare providers. Now this is where everyone wanted to go. Part of HIMSS, this group who pushed this, are also the state government agencies and the federal government agencies, all who want access to all of this data without consent. Here is what the CDC said. They're focused on efforts to improve data collection capabilities by accessing information buried in EHRs and utilizing cloud-based applications. At HIMSS, Eric Schmidt, former chairman of Google, talked about what a great thing it was to have EHRs, because now they can access all this data, and he told everybody, get into the cloud, where it's, of course, readily accessible. And under HIPAA, Google can be a business associate and have access. Okay, here is HHS's plan for the National Medical Records System, called the Nationwide, first it was the National Health Information Network, NHIN, then it was the Nationwide Health Information Network, NHIN, but then they changed it to NWHIN, and now it's called eHealth Exchange, and it's run by the Sequoia Project. And what you see on there is the red is the internet, and those six-sided figures are the nodes, which will access information around through the internet. And that's what's being created here by the EHRs, the meaningful use mandate to hook up to the grid and to share with the public health agencies and others. Okay, so Americans actually want medical privacy. And they want it at different levels for different things. So only 1% are willing to share, to allow researchers access without consent. It's a little interesting with the baby DNA. Because of our work, some Michigan researchers did a study, and they talked to parents. And they found out that only 28% of parents were willing to have research without their consent. But they not only found out that, they found out that parents who were okay with the research, wanted the research to be, they wanted to know what the research was, not just like wide open research on their child, but what the research is. And then 15% are taking steps to protect their own medical privacy, things like not telling one doctor about another doctor, or giving a false name, falsifying information on the questionnaires, delaying access to care, completely avoiding care altogether. And this was before the EHR mandate. So now people are probably taking even more steps. But see, it's harder for anybody to get out from under the grid if they go to see a doctor, which is one of the reasons why we've got something called the Wedge, which I'll say in a moment, where these doctors don't share any information with anyone. The All of Us, the Precision Medicine Initiative, has come up with a very interesting thing. They wanted all these people to just readily give them access to the EHR, to their information on the EHR, and 20 to 30% of 4,000 people, the 4,000 who are in, have refused that consent. There was a Gallup study in 2000 that gave these figures that you're looking at regarding how many thought medical information should be confidential. Then there's the constitutional right to privacy against the government. So constitutional is just for the federal government, and if you've got a state constitution, which most states do, often that's in the state constitution as well. So you know about the right of people to be secure in their persons, homes, papers, and effects against unreasonable searches and seizures without an oath. And then here's from U.S. Supreme Court Justice Brandeis, who talked about the makers of the Constitution and to protect the right, every unjustifiable intrusion by the government upon the privacy of the individual, whatever the means employed, including EHRs, although he didn't know about EHRs at the time, must be deemed a violation of the Fourth Amendment. And then here, of course, is the Hippocratic Oath, which you're quite aware of. But the people who want access to the data don't like the part where it should be reckoned as secret. And here are some actions to protect privacy, protecting from government and corporate controllers. It's just a limited list. There are lots of things that could be done. Adding consent requirements to all healthcare legislation, ending the EHR, MIPS, APM mandates. Interestingly, Seema Verma, the CMS administrator, talked about there are some things that are going to happen new with MIPS, and the head of HHS is considering getting rid of MIPS. And those four things, those diagrams in there, getting rid of it, but judging you, scoring you based on patient surveys and claims data. So still gathering information, but not requiring you to submit it. And then informing patients. I'd love if doctors did this. Tell those patients about everything that's going on. Let them know. Inform them that HIPAA doesn't protect them. It would be the best thing for them to have you truly as their advocate and helping them to realize about all this outside control. Refuse to hook up to the grid, refuse to conduct bedside research. So the federal government is putting out things that are for bedside research, like the Comprehensive Joint Project, where certain hospitals are mandated and a bundled payment is given, and it lasts for this amount of time and has to cover all the expenses and not just about the comprehensive joint replacement. Okay, and then freedom from third-party payment. So this is our big thing, right? The only way you get to be free is he who holds the dollars, he who holds the data makes the rules. And so we started something called the Wedge of Health Freedom. And the idea here is that we're going to capture everybody who right now is doing direct pay, including specialists, including we just got an MRI center from Oregon that came out. We have a very cute name called Lumps and Bumps Doc. Can't remember, I think it's from Texas. And we have cardiologists and orthopedists and people who are doing direct pay. And their information, to following our 8 principles, which is on that blue card in front of you, on the back of the blue card are 8 principles. They follow those. So our idea here is to get everybody who's doing direct pay now, which some people say is 700 to 1,000 physicians. Some say it's more than that. And I think it will only increase. There are 48% of doctors now polled by the Physicians Foundation 48% of like 17,200 doctors polled who said they're getting ready to leave the practice of medicine or go into concierge where they have significantly fewer patients and no outside interference, or they're going into non-clinical medicine. 48% as the baby boomers are just expanding, right? And so we want more of these doctors to do direct pay. And I showed this card to an orthopedist about a year ago, and she read those 8 principles, and she's reading them, and she says, great. And she looks up at me and she says, so all I'd have to do is my job? And I said, yes. She said, oh, it'd be wonderful. I think that's where every doctor is today, who is tired of doing twice as much paperwork on the computer as patient care, as the studies show. So here is a card that we are sending to physicians, postcard, that we're sending to direct pay physicians around the country to try and get them to come in. You'll see that this diagram here shows you why we called it the wedge. You see that little wedge in there? That's the invisible wedge. A lot of the public doesn't know that there's anything like direct pay. And they don't know why. If they did know, they should look at it. But the fact is that a lot of the costs are so significantly less, and particularly with today's high deductibles, they can end up with more money in their pocket if they just go to a direct primary care doctor or to a fee-for-service physician, because they'll never hit that deductible, and they'll end up paying less. But we called it the wedge to make it visible, to make it bigger, and eventually we'd like every doctor, every hospital, every surgery center to be doing it the wedge way. And the wedge way is only direct. It's just direct. That's all it is. We just had to give it a name that the public could grab onto, because that's the way to get the third-party payers out. That's the way to get out of managed care. That's the way to go back to traditional insurance. And traditional insurance, in case none of you know about this, I had a guy who was almost 80 when I gave this presentation on just the wedge, just a wedge presentation. He said, he listens to Sandy, goes, well, that's how it used to be. He said in the early 1970s, he had to have cardiac surgery. And so his insurance company sent him a check for $68,000, which he used to pay his doctor in his hospital. He said it was simple. I said, yes. And so all of these people in the middle are making a lot of money, and not money that you're going to get, but money they're going to get, making sure that you get less. This is sort of where we want to take it. This is how we envision it right now. The payers on the top, whether that's the government or the health plan or whoever, and they're making all the rules. And that's a triangle, and nobody knows what's happening in that triangle. Data and dollars are going round and round and round, but the payer's in control. And so we want to disassemble the triangle and make 3 separate relationships: patient, doctor, patient, hospital, patient, insurer, just like that guy nearing his 70s said it used to work. And speaking of privacy, coming soon, this book right here, Big Brother in the Exam Room, where I will talk about how this has all transpired and how it is leading us to socialized medicine. Because he who holds the data makes the rules. The merger of the financing and the delivery of care and the control of the practice is happening through the electronic health record. And this is not just any old electronic health records. This is the government EHR that I'm talking about in the book. And there are people who have electronic health records who love their electronic health records. And they have kept them, and they have taken the financial hit of the penalties, the government penalties, just to keep their own EHR, which is not hooked up to the grid, but works for them. So this is about the safety problems, the privacy problems, the control problems, the autonomy problems. When I was at HIMSS, I listened to lots of things, but I listened to this one doctor who has become an administrator talk about how practice guidelines, how doctors don't have to follow them, but if he had his druthers, he would gently force them to follow them. And he said guidelines that are treatments that a consensus of experts decides is the way medicine has to be practiced. And all of that happens through the government EHR and the tracking and the payment and the pressure. And one of the things he said is, the way I'd like to more pressure them in is to have the EHR question them earlier if they really want to do this practice. So anyway, I think it's, this is my presentation. I hope you might consider getting the book once it comes out, because most people think the EHR is, like that lovely little phone in their pocket. But the EHR has a big plan. The government EHR is part of a big plan to control the practice of medicine and to make you all the tools to make it happen. So my name and contact information, and if you have any, I don't think it's questions now, right?
Yeah, well, we have a little bit of time, maybe like one or two questions.
Okay.
Go ahead.
You.
In a practical way, it sounds like, so every clinic you ever walk into, there's that digital forms as you can provide this stuff, and our privacy policies, et cetera. I just want to say, if you don't sign that form, right, and I'm just kind of curious, I can imagine them either not seeing you or not understanding what's wrong. Would you still be able to see a doctor if you didn't sign that form?
So it depends on the practice. So one of the things, so it depends on what the form is too. Are we talking about a straight HIPAA form? Are we talking about a form that has just one little sentence in there about I acknowledge that I have received the notice of privacy practices? Are we talking about a multi-consent single signature form? I'm not sure which kind of form you're talking about, but what we hear from patients is, so that form that was up there is one that we got from a patient who walked out because they said, we're not going to treat you if you don't agree to all of this. And she was not willing to agree to all of that, right? But there are some clinics that have a single HIPAA form, just a single one, and they've got consent for treatment and payment separately. So it really does kind of depend, and it depends on the clinic. Sometimes patients have called our office and they say, will you talk to the administrator? So we're on the line with the administrator, explaining the law to the administrator. And then the patients get through. Sometimes they refuse. One of the last times I was at an orthopedist for a toe fracture, I think it was when it was, there was one of those electronic, the iPad, right? I got to a certain point and I said, I'm not filling that out. And so then they had to call the management, and the management had to figure out exactly how to bypass all of that. And then they told me, I don't know if the doctor will see you. Well, I knew this doctor would see me because this doctor knows me. And as a matter of fact, they went to the back and they said, she's refusing to sign the form. And he looked up and he said, is it Twila? Yeah. And the thing is that he knows that nobody has to sign that form. And nobody has to sign all of those things in the questionnaire either. I just said, I'm not going to answer all those questions. You don't get to gather structured data. I mean, that's what they all want. The EHRs, they want structured data. That's why it's coming to you now in an iPad, so that it's structured and can be put in all these fields and then shared and analyzed. Yeah.
My question is, as far as what exactly the Wedge is it a database that collects
Oh, we didn't have that picture up there.
Yeah.
It is. It's a website. Thanks for asking. It's a website, and which just invites people to come and invites people to find a doctor on the Wedge. And so there is a find a practice map. We have about 225 practices on it now. We have 2 in Hawaii, and my staff says we need a site visit. We've got one in Alaska. And so all of those, the doctors just join, and then their clinic has a site. It's completely free to patients, completely free to doctors. It's part of our nonprofit mission to bring freedom back to healthcare.
So like a doctor who practiced direct primary care, direct pay,
Yep.
no insurance Medicare, could register and be visualized on this map.
That's right, and found. Yep, so we receive, every once in a while we'll hear from doctors. So one doctor told me that he got 2 Wedge patients 2 days in a row, right? So, like that sort of thing, yeah. Yep.